Hello, I'm Bruce Spurlock, a physician and healthcare leader committed to helping professionals and decision makers navigate change with clarity. On Viral Healthcare, we examine the ideas that are spreading throughout healthcare and what makes them work, what doesn't, and what it takes to implement them effectively. On today's episode, we're going to talk about some of the things we discussed earlier this week on the surprise, on the innovation that turned out to be more than it really promised early on. So, this is the topic of rapid response teams that came out around 2003, 2004, but got popularized when the Institute of Healthcare Improvement promoted the concept of an RRT throughout the country. Rapid response teams were really formed, and they're called several different things. Sometimes people call them METs, or medical emergency teams, or high acuity response teams, or recovery teams, HARTs. There's a lot of names for them, but the principal idea that they're doing is they need to intervene before somebody deteriorates so much that they have a cardiac arrest, they unexpectedly and rapidly get transferred to the ICU, or something worse will happen. So that's the idea, that they were trying to get this early so that these bad things wouldn't happen to patients. And the idea was that there's a small team of people, mostly experts from the intensive care unit, nurses, respiratory therapists, maybe a physician or two, that would go rapidly when a nurse called for help, when a patient was deteriorating and they just wanted to get things taken care of rapidly without having to figure it out or call problems or call people up to get them to come help them. So that was the idea. The pushback came back in the day, back in the early 2000s, that the data was squishy. The data may not have actually supported it because this is one of these kinds of things that you have to implement well. And so when there was a large multi-centered trial of patients on it, the lives saved, the number of ICU transfers, the number of cardiac arrests that were prevented were not statistically different in the two groups that did it. What they didn't do at the time was look at how effective implementation was, and that's something we learned later was crucially important to make rapid response teams viable. I love these surprises. I love these kinds of situations when somebody overcomes these barriers, the naysayers, the pushback that came from academia, from people that were rigorous about methodologic analysis of whether these interventions worked and maybe we should be spending our time somewhere else. What happened at the time, which was really interesting, was there was a nursing shortage. And what people quickly found out, that if you were offering a rapid response team, if you were able to support the less experienced nurses just coming out of their training programs who might be kind of worried that there's going to have something bad happen on their shift or to someone of their patients, that you could actually recruit more effectively at the same price, at the same cost, maybe even less than those hospitals, those institutions that didn't have the rapid response team. What was it all about? They were meeting a need, because in reality, escalation was happening in hospitals. Escalation is a natural focus and job of every hospital in the country. They need to help watch for deteriorating patients and intervene quickly than if they were at home or in another setting. And yet it wasn't being done well. So it was an obvious problem that people were trying to solve. And it spread really rapidly. But one of the things we learned over the next couple of years of implementing rapid response teams was not everybody did it well. Some people were putting in the structure and the idea, but not really getting the change in the way the work was done, not integrating it with care delivery, not making the culture of the organization support the idea that anybody, maybe even family members, could call a rapid response team if they worried and were concerned about deterioration. It turned out that now, many, many years later, more than 20 years later, rapid response teams are part of the process. Just about everywhere people do it, and we don't even think about it. And recent studies still suggest that some hospitals do it better than others. This would suggest that not only do you have to implement it well, you have to maintain it. It's kind of like blood pressure. You just can't forget about something once you started treating or in getting involved with a new system. But it doesn't require a lot of maintenance. It just requires some ongoing evaluation for it. So the surprise story was, in the face of opposition, powerful opposition, with not the strongest data to be basing the innovation on, it turned out the implementation was the key. Implementation was a factor between success and just having something that sounded good. Maybe it helped recruit nurses, but it really didn't make a lot of difference. So For today, the things I want you to think about, the questions I want you to ask yourself is, are we trying to do things just for the moment? Or are we trying to do things because we have an obvious problems? Is it something that the frontline people in my organization can understand, or is it just a group of specialists? Do we use new language to try to describe something, or is the problem so obvious, or we can make it more obvious that people will accept it and rapidly adopt it? It's not really flashy, not really, all that brazen and dramatic in what it does, but there are innovations out there that are surprises. And the main reason is because they look and sound and act a lot like what we learned from rapid response teams. I'm Bruce Spurlock, and I hope you enjoyed this reflection. If you want to follow me on viral healthcare, you can go to your favorite podcast platform and check it out there. And we'll be back on Tuesday with a new episode where we look at specific details about why you might have early warning signs about whether a trend is a hype or whether it's reality. I'm Bruce Spurlock, and I'll see you next time.